The original next speaker have to leave early, so Giselle Viana will not lecturing anymore today. So the next speaker will be Yu Wu. She is a medical student from New Zealand, and she will lecture on a basal carcinoma arising in a chest wall keloid case report. Please proceed.
Hello everyone. Today I will report a rarely clinical about the basal cell carcinoma secondary to the chest keloids. And just a short introduce myself. My name is Wu Yu, and I'm come from the Victoria University of Wellington, which is situated in New Zealand. As we know, keloid is a clinical condition characterized by Beijing fibrous tumors, which is resulted by abnormal collagen metabolism. Due to the perceived pathological stability, most patients and even our clinical views in the purely region, so that build blind spots. Most measurement evolution is rarely suspected and almost never reported in the literature. And in our case, the patient is 85 years old male who born in 1941, and his disease history is around 80 years. And in person, he has a severe ulceration, exudation, and a new focal tumor formation. And this graph illustrates the disease history about this patient. As we can see, his first keloid forms on the chest as he is 5 years old in 1946. And as he is the age of 20, the lesion surgery removed without the radiotherapy. And between the 1980s to 2050, there are 35 years latency periods. The keloid is really stable in those years. And in percent, the third lesson ulcerations rapidly, forming a distinct swim-sized mass. And we can see in the clinical manifestation in the macro view, it was a lot of atrophic scar on the upper chest and a lower side with massive lesions on the left chest. And we can see in the right image, it was the tumor covered in the plasmos, and the surface is right. And the colorized base is right, south, and resilience. And for the radical resections and reconstructions for these patients, we have removed nearly 3 centimeters margin from the tumor edge that makes the surface have a more safety surface on the surgery. And we to make sure the treatment for the softness, we have double conformed the physiological specimens to conform the negative stadiums. And we created internal thoracic pacillary artery flaps. And in our patients, finally, from the physiological conformed that the basal cell carcinoma secondary to the keloid. Histology definitely separates this from primary scar formation, showing distinct basal cell layer origins adjacent to existing keloid stoma. And the physiology different diagnosis spectrums, there have 3 different diagnoses. For the majorly authors, it was normally observed. SCC arising directly from select scar tissues, often observed in clinical practice, and like the keloid-like BCC, a specialized BCC that inherently generates abnormals, keloid-like collagen fibers as it grows. And our case just like the BCC secondary to keloids, it was a anomaly. It's distinct malignant tumor originating from basal cells layer, growing on the top of pre-existing historical keloid foundation. And it's very important to separate the structural distinctions. In our case, it's BCC secondary to the keloids. The malignancy invited into the pre-existing spite of the keloids, and the tumors develop superficiality, eventually covering the separated underlying keloid mass. And for the case which is reported in 1996, like the keloid, like BCC, the tumors act as a generator and contains the interwoven in addition to the aggregation of the basal cells. And this table summarizes the diagnosis. Just like the case about Morgerlin's, his originates the scar tissues anaplasias, or it originates the basal cell layer, and interwoven abnormal collagens with the tumors. And our case, distinct keloid foundation beneath tumors. Here is to this presentation. There is exactly one document instance of the malignant tumor secondary to keloid in global medical literatures, and the literature is reported by Golder M. Which is reported in 2016, and it was name of cutaneous basal cells carcinoma arising with a keloid scar. And the difference between those two cases is around the age, keloid latency, location, subspike triggers. And in the 2016 case, the patient is a 23 years old female with the disease about 2 years, and his keloid grew around the ear, and it's triggered by the sun exposure. And in our case, the patient is an 85 years old male. His disease history is around 80 years, and it's grown in the chest, and is triggered by the chronic scratching and the mechanical irritation. And the clinical pragments in this case, just make us to shift from the privilege strip to the curative elimination. For the privilege strips, the keloid viewed purely as a vision aesthetic issues, and actions for that is prevalence management, observation, and symptom controls. But these methods have a risk. It leaves underlying abnormal metabolism active, allowing a disease of chronic inflammation to trigger management transformations. And our method is curative elimination. The keloid carries a distant hidden risk of basal cell malignancy, and it will result in eradicate the disease foundations, permanently eliminating the risk of the secondary management evolution. So what we can do for the patient is like to proactive intervention and demand for the curation. Thanks for your patience.
Very well. Are there any questions?
The audience really, it strikes me, sorry, I will make it. It strikes me that we have discussed the symptomatology of keloid scars, the irritation, the scratching and itching, And particularly like LeBron, you see a lot of patients. How many have you seen with malignant change? I mean, BCC is not malignant, but with malignant change. I was just intrigued.
I've never seen one.
Which is interesting, isn't it?
So is it possible that it actually blocks it because of how dense the keloid tissue is to have something form on top of it and then invade from there?
So I mean, I've never seen it, but the one thing that we have evidence of, and we're publishing our paper, but there's what we believe is a link between keloid disease and incidence of cancer, not in the keloid, and we submitted an abstract. This was in like 2018, and then in 2020, I think, or 2021, there was a Taiwanese population study where they had like 47,000 patients and I think like 15,000 patients with keloids, and they showed that there was an increased incidence in breast cancer in women, and prostate cancer and some skin cancers. So I think the link is with the M2 macrophages. I think that patients that develop keloids have they're predisposed to M2 response to tumorigenesis, and I think that's the link not only with potentially cancer development but also worse outcomes. Because in our study, we only looked at breast cancer. Patients had earlier onset and later stage breast cancer in women. And there are already papers that show that M2 macrophages, specifically in African American women, are associated with poor prognosis with the M2 macrophages.